So next protocol we're going to go over is the cardiac arrest protocol. First one we'll do is the adult protocol. Um, some minor changes here. Oops, sorry. So for EMTs, nothing's changed for you guys. Still focusing on CPR during your patient care. Apply and use the AED as early as possible. Minimize scene time for trauma. And manage the airway as appropriate. And request an ALS intercept. For advanced EMTs, Ambulance Inc. was already doing this, but now on a state level, you guys can administer epi during a code. So a reminder, that's 1 milligram epi, the 1 milligram per 10 mLs concentration every 3 to 5 minutes during a code. Make sure you establish IV/IO access. I highly recommend if you can't get an IV on the first try, just going straight to an IO, because the faster you get the epi on board, the better possibility of the patient having ROSC. Again, do not delay if it's a traumatic arrest for an IV, airway management, or any meds. So, paramedics, not a whole lot changed for you guys either. Just want to remind you guys, initiate chest compressions early as possible. Apply the defib pads as early as possible. If you find a patient in VFib, VTAC, and you shock them and they're still in refractory VFib or VTAC, consider changing pad placement to the anterior posterior. So, a lot of times most of us will start with the anterior lateral, which is close to the right shoulder or the right side of the chest, and the left side or left flank area. If that placement isn't working, go to anterior posterior. Again, establish IV/IO access. If you don't get the IV on the first try, go straight to an IO. For patients found in VFib or VTAC, you don't give epi until after the second defibrillation shock. And then consider amiodarone, lidocaine, and magnesium as appropriate. If you find asystole or PEA, focus on CPR, ventilations, epi every 3 to 5 minutes. I would stay closer to the 5-minute mark because we have 6 epis in the bag. If you stay close to 5 minutes, that should get you about 30 minutes on scene. And that should be enough to work it for 20 minutes in contact med control and go from there. Treat your H's and T's. Airway management as needed. Remember, IV/IO administration of medications is preferred over ET tube. Reason being is most patients who shouldn't have a problem getting an IO on. And if you continuously give meds down the tube, you're eventually going to drown a patient in cardiac arrest. For a traumatic arrest, consider bilateral needle decompression. I also just want to take this moment to strongly encourage everybody to start working their codes on scene. We'll do more training on that later, but there's a lot of research that shows working a patient where you find them, whether it's in the house or in the yard or wherever, their neurologic outcomes are better, their ROSC rates are better. So just keep that in mind when you're deciding how to run your codes.